The following podcast is part of a certified educational activity titled Alzheimer's Disease Case Conference, Building Confidence in Visual Interpretation and Quantitative Analysis of Neuroimaging. Access the entire activity and complete the post-test at peerview.com/KNB860. Downloadable slides and practice aids are also available.
Good morning, everyone. My name is John McConaughey from the University of Alabama at Birmingham. I'd like to welcome you all to the Alzheimer's Disease Case Conference. And the goal here is to build confidence in visual interpretation and using quantitative analysis for neuroimaging and evaluation of patients with Alzheimer's disease. I'm joined by Phil Kuo, who's an expert in molecular neuroimaging, and he'll, in a moment, start off with the first part of the program. Today's goals, because of the advent of amyloid-targeting therapies, radiologists, neuroradiologists, and nuclear medicine physicians need to be ready to meet the increased demand for amyloid PET imaging in patients with or at risk for Alzheimer's disease. Currently, amyloid PET is the gold standard for confirming amyloid positivity clinically, and it is used to evaluate treatment response and monitor amyloid clearance. I'm going to be talking about quantitation, which can support visual interpretation of amyloid PET and allow you to select patients who would benefit from treatment and evaluate their response to treatment. And as we talk about standardizing both the visual and the quantitative PET findings, it'll allow you to more effectively communicate with referring physicians and improve patient care through the most accurate assessment possible. So with that, I'm going to turn this over to Phil, and we'll get started.
To start, let's take a stroll back in time. This was the traditional method when I'm a retired internist, so back in the day when I was taught about how to assess Alzheimer's disease, it was clinically and functionally, all right? We went from preclinical AD, where there was no symptoms, but if someone were to pass away at that time and you were to look at their brain, they had amyloid, and then mild to severe in that continuum, depending on how they interfered with everyday activities. Of course, we know that there's much more going on in the brain besides what we can see from the outside of a patient clinically, and what we hear functionally is their capabilities. And so there's this real movement to categorize patients with biomarkers. And the first biomarker to become abnormal in Alzheimer's disease is that pathologic protein amyloid that gets deposited in the brain. So it's the first category of biomarker to become abnormal, and this is a frequently shown cascade where you graph where you first it's amyloid, and then the second pathologic protein that becomes quote unquote positive is tau, and then you start to develop symptoms, particularly with neurodegeneration and neuronal loss. Now, importantly, amyloid is necessary but not sufficient. It is abnormal. It actually accumulates significantly even a decade or more before you develop any symptoms. So the fact that you have amyloid depositing in your brain does not give you Alzheimer's disease. Alzheimer's disease requires symptoms. And in the amyloid cascade hypothesis, you get amyloid first and then tau and then the symptoms. So the evolution of the pathologic / biomarker staging was actually updated very recently to add even further nuance to the system. And that was just last year, the revised criteria for diagnosis and staging of Alzheimer's disease from the Alzheimer's Association work group. And in this, they actually have now split into two core biomarkers. And again, as John said, the references are here, and you can upload them from the PeerView website. So all these are references are available for you. And an abnormal core 1 biomarker result is sufficient to establish a diagnosis of AD and to inform clinical decision-making throughout the disease continuum. And in that abnormal core 1 biomarker on imaging is amyloid PET, okay? Core 2 is actually tau PET, all right? So we're not going to go into tau PET in great detail in this talk, but tau PET is also a very important emerging imaging biomarker as well. Other biomarkers that are important because they're indicative of non-specific processes, but they could be relevant, are ones of neuronal injury, which is anatomic MRI with volume loss, as well as FDG PET, which we're familiar with, because it can give us a more broad differential, for example, of frontotemporal and other types of dementia. And then of inflammation, which, for example, we have non-approved methods of doing that by PET, and biomarkers of non-AD copathology, for example, vascular injury, which we can do by MRI, and alpha-synuclein, which is responsible for the Parkinsonian syndromes. And so more and more importance is being placed on the effect of coexisting pathologies, and this was put into the revised criteria, where as patients get older and older with the additional decade, the chances of them having coexisting pathologies, amyloid plus something else, for example, alpha-synuclein, is really being revealed as more and more important, because real world things get complicated, and having coexisting pathologies can really push back the number of years, or accelerate the timeline for when you would develop symptoms. In this biological staging, again, amyloid and tau is part of this revised criteria, but amyloid really is still central. So in PET stage A, you're amyloid positive and tau negative, and then with advancing PET stages B, C, and D, you are still amyloid positive, because that is the first biomarker that becomes positive, and then you have increasing burden of tau extending from the medial temporal lobes into the neocortex and the parietal and frontal regions. But amyloid is still the crucial initial staging core 1 biomarker. Fluid biomarkers are here to stay. They're very commonly performed in the evaluation of patients when they're being evaluated for potential Alzheimer's disease, but they're not interchangeable with PET imaging. We're here at RSNA, so we don't have to point out the fact that there's no regional information from serum or CSF. You just get a number. You have no regional information, unlike PET. And the soluble metabolites of amyloid are what you really measure, okay? You're not actually seeing the amyloid deposits in the brain. You're not really measuring those. You're measuring the metabolites that come out in the blood and the CSF, or you're drawing correlations with other soluble protons, not even amyloid, okay? And very limited data on using it for monitoring treatment response, really. The monitoring of treatment response really is the domain of amyloid PET and not fluid biomarkers at this stage. The CSF, they have invasive issues, right? Not everyone wants to get an LP. Some people can have contraindications of that, and of course you can get the annoying LP headache that may need a blood patch or two afterwards as well. And you can get false positives in the early stages as well as false negatives. No test is perfect. If you increase sensitivity, you decrease specificity, and vice versa. Blood biomarkers are getting there, and of course that avoids the issue of the LP, so you can see the attractiveness to blood biomarkers, but limited real-world experience there, and that may be affected by other patient factors, for example, kidney disease. We need to figure out in those special patient populations where the blood biomarkers still could be erroneous. And the PET and fluid biomarkers of Alzheimer's disease are really complementary. They should be used together. I think every expert agrees they're both here to stay. One's not going to replace the other. And one of the key things, of course, is that PET gives you the extent and distribution of the amyloid in the brain, not its metabolites. We're going to move on now to the visual assessment of amyloid PET. So this is a quick primer on how to interpret amyloid PET. Okay, all three of the radio tracers have their own specific read protocol. Okay, and when you go to the PeerView website, you'll find the links to all of those, and those were tailored specifically to the tracers with knowledge of the neuropathological standard of truth, okay? So would recommend using those. But they all have very similar basic principles, okay? They all, if you will, stain white matter when they're negative. So a normal or negative scan shows a white matter pattern, okay? You just don't see nothing. You actually see a white matter pattern like you'll see here, okay? And an abnormal scan shows uptake in that gray matter. It stains those amyloid plaques in the gray matter, in the cortex. So now you have activity in the gray and white matter, so which results in the loss of contrast between the white and gray matter. One way I describe it is, here you can take your cursor and trace out the white matter tracks in a negative scan, and on a positive scan you can't trace out those white matter tracks, and that activity extends equal intensity all the way out to the edge where the gray matter is, as it is periventricular, where the white matter is. All right. These are the 3 FDA-approved F18 radio tracers, florbetapen, florbetapir, and flutamidamol. Again, there's specific reader training for each one of these, so we recommend you use that specific reader training. On the side here, I have I figure a lot of neuroradiologists might be here, so this is a DTI of the white matter tracks to really show you that the PET, when it's negative for amyloid, looks like a lower resolution white matter pattern that you would see on a DTI map of your white matter on an MRI. Okay? So very easy to spot that. And you lose that pattern when they become positive with all 3 of the approved tracers. So many of you may be used to interpreting FDG PET for many years. Inherently very, very different. Okay? FDG PET is our classic nuclear medicine exam that's really functional. How we distinguished ourselves from the rest of radiology, which is anatomic, nuclear medicine is functional. This is sort of the next generation of where nuclear medicine has gone. We're now molecular. Just like if you talk to pathologists now, there's molecular pathology. This is why the Society of Nuclear Medicine changed its name to the Society of Nuclear Medicine and Molecular Imaging. This isn't so much functional. This is a radioactive pathologic stain, okay? So, and indeed, a positive and negative scans, these were calibrated to none to sparse plaque, which is not consistent with Alzheimer's disease diagnosis pathologically, is a negative amyloid PET scan, and positive is a moderate to frequent. So this is really at the junction of imaging and pathology, these amyloid PET scans. Okay, I'm not going to go through all the different signs, but this is a radiographics article that I published a few years ago with one of my former fellows, Dr. Lundeen. And so I got a lot of good feedback that these are handy. This is in the temporal occipital region, you get this mountain ridge type pattern when it's negative and becomes like a flat plain in the desert when it's positive. This is a very nice sign. A lot of people forget when they're looking at amyloid, remember your neuroanatomy. The interhemispheric fissures are lined with gray matter. So you have this big negative region in the middle because it's not only the interhemispheric fissure, but the gray matter on both sides that's negative. And when it's negative, you get this double convex line sign. When it's positive, the activity will almost touch in the middle, and so that's given the name the kissing hemisphere signs. And the other one that's kind of nice, because I like to emphasize that when you're looking at these amyloid PET images, look at more than the axial. The coronals are very helpful. And in the frontal region, for example, when it's negative, it looks like a tree in winter where you just see the branches because they've lost all their leaves, right? It looks like the white matter pattern. And in the summer, when the branches are covered with leaves, you don't see the branches anymore, and that's like the tree in summer, as long as it's not a drought, will be a positive. So tree in summer is a positive amyloid PET scan. Tree in winter is a negative amyloid PET scan because you can see the branches. And the kissing hemispheres, where the activity almost meets in the middle and the interhemispheric fissure, is positive because that gray matter lining the interhemispheric fissure is filled in with radiotracer. Okay, so this is how John and I prefer to dictate it. We don't say in our report, in our impression, this is consistent or not consistent with Alzheimer's disease, because that really requires the clinical information, all right? We're here to report out, almost like pathologists, right? A normal or negative scan indicates sparse to no neuritic plaques and is inconsistent with a neuropathological diagnosis of Alzheimer's disease. Conversely, an abnormal or positive PET scan indicates moderate to frequent amyloid plaques. Neuropathological examination has shown this amount of amyloid neuritic plaque is present in the patients with AD. I basically take this word for word out of the prescribing of information from one of the tracers. It shows a nice correlation to the pathology. So the reports, pretty standard, start with the indication, technique, the type of radiotracer, the administer activity, the injection site, comparison to any priors, which is now particularly relevant, as John will go over. Findings, we go over, is it positive in which region? And then a clear impression, just like we just stated, whether amyloid deposition is positive or negative. Very, 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 very rarely will we ever say borderline, and if you do, you need to state why it's borderline. First case, a man in his 80s presents with increasing difficulty with memory for the past year. He actually has a history of Parkinson's disease and a family history of Alzheimer's disease. And this is his F18 florbetapir PET scan. Okay, I'll have you look at it just overall first. Generally speaking, you want to start at the cerebellum and then move your way up to the vertex. The cerebellum is going to give you your negative control until the very, 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 very latest stages of Alzheimer's disease. You will not get amyloid in your cerebellum. So this is your control for what you would expect would be a negative gray matter in the cortex, this gray level of activity in the gray matter of your cerebellum. Okay. To emphasize the gray matter, white matter contrast, these are MRIs, again showing the white matter pattern, and you can see a negative uptake in the cerebellum looks like the white matter pattern you see on a DWI MRI. Going higher up, this is your temporal occipital ridge of white matter, as you can see, nicely emulated in this PET scan, white matter pattern on the temporal occipital region. A little higher up, white matter pattern in the frontal region as well, okay? And then coming up into the high parietal and frontal regions, you can see that gray matter lining the interhemispheric fissure. When it's negative, it gives you this big negative clear space here as well, okay? And you see this clear white matter pattern of your centrum semiovalia on both sides. Okay, so another quick question for our audience. How would you interpret this amyloid PET scan? Negative, positive, borderline, or I'm not sure? Okay. John, next year I think we should be allowed to put in music requests of our own preference. All right, yeah, great job everyone. So again, negative, a real distinct white matter pattern in all those regions, so negative scan. Okay, almost everyone got that right. Good job everyone. So this scan showed normal, which indicates sparse to no neuritic plaques and is inconsistent with a neuropathologic diagnosis of AD, and the patient remained stable on multiple years of follow-up. Next case, a man who's 63 years old, presents with worsening memory problems and was diagnosed on cognitive testing with mild cognitive impairment. He's been running his own business for over a decade, but he's noticed real problems. He's had to rely on memory aids, and he's having more trouble with accounting. And this is his F18 Flor-Beta-Beer PET scan. All right, quick overview. Again, start at the cerebellum and then work your way to the top. All right. How would you interpret this amyloid PET scan? So looking at this, can you see a white matter pattern here? Can you trace out where you know that white matter to be in the periventricular distribution, the perioccipital ridge? So think about that. White matter pattern, yes or no? And then answer the question, how would you interpret this amyloid PET scan? Negative, positive, borderline, or I'm not sure. Okay, yep, great job everyone. Again, almost everyone got it. Positive scan. There's no white matter pattern here. Actually, every region here is positive in the cortex. You have activity going all the way out to the edge of the brain where the gray matter lies. All right. And also, just a companion slide for this one. As you can kind of see back here, for those of you who may have gotten this wrong, it got a little tricky back here, but this is very common. Sort of in the high parietal region here, we have atrophy. We have these really deepened and large sulci, and it can create a pseudo white matter pattern, okay? But this is actually still positive if you actually track where the gray matter is, if you line it up with the MRI. But where there's atrophy, you should avoid interpretation of those. There's so little gray matter there, it will look negative because you just don't have gray matter because of atrophy. So it's probably the most challenging reason for, most common reason for a challenging amyloid PET is atrophy. And my best advice is to use your anatomical imaging and just avoid interpretation of areas that are atrophied and focus on the areas with no atrophy or relatively less. And this patient was treated with the symptomatic pharmaceutical donepezil, decided to sell his business before we would ruin it to help with his financial situation. And unfortunately, his MMSE further declined a year and subsequently further even after that. So the appropriate use criteria for amyloid PET was first published in 2013, and then 12 years later was published the updated appropriate use criteria for amyloid, and we actually added tau PET, just like the biomarker staging criteria added emphasis on tau. And the goal of the updated AUC was to assist clinicians in identifying clinical scenarios in which amyloid or tau PET may be useful for guiding the diagnosis and management of patients who have or are at risk for cognitive decline. Not going to go through the whole thing, of course. The reference is there for you. But there are 17 clinical scenarios divided into 4 major patient populations: cognitively unimpaired, subjective cognitive decline, mild cognitive impairment, or suspected Lewy body. And a panel of experts rated this as each one of these clinical scenarios is rarely appropriate, uncertain, or appropriate. Long story short, you can get into the details, but big picture, amyloid PET was appropriate for mild cognitive impairment. The majority of scenarios that include mild cognitive impairment, it was appropriate, and rarely appropriate at this point for cognitively unimpaired patients, okay? But I want to point out 2 specific clinical scenarios that we had to add to these update criteria. Clinical scenario 14, to determine eligibility for treatment with an approved amyloid-targeting therapy, and clinical scenario 15, to monitor response among patients who have received an approved amyloid-targeted therapy. And amyloid PET received a 9 and an 8, very appropriate rating for both of those clinical scenarios that are now relevant in clinical practice. So theranostics, a lot of people have different definitions. I like this one. A theranostic system integrates some form of diagnostic testing to determine the presence of a molecular target for which a specific drug is intended. Many of you may know we've done great strides in nuclear medicine, particularly in oncology, in theranostics. But the radioactive drug that you're going to treat patients, the drug that you're treating people with don't have to be radioactive for this to be a theranostic system. The original one, for example, HER2 for breast cancer and Herceptin. It doesn't have to be radioactive. And in this case, PET is coming into play in the beginning because the era of neurotheranostics is already going in full swing. And a pivotal trial that started off this was the Clarity AD trial, published in New England Journal, with lecanemab. This was the first fully approved anti-amyloid antibody targeted therapy. And why did it get approved? It did not stop, but significantly slowed the progression of disease in patients with mild cognitive impairment or early Alzheimer's disease. As you can see here, 27% slowing by lecanemab at 18 months. Some would describe that perhaps as a modest benefit. And it also showed this proof of mechanism where the mean centiloid score, which John will go over, was 78 at baseline. And at the end of 18 months of the anti-amyloid antibody therapy, the mean centiloid score, which is a measure of how much your amyloid burden is on your brain in PET, decreased to 23, which is essentially close to negative. Okay? The second pivotal trial was this phase 3 trial called TRAILBLAZER, which was the second fully approved anti-amyloid antibody therapy, donanemab. This was really interesting because this patients who were enrolled in this had not only amyloid PET, but tau PET as well. And this, no matter whether it was the low to medium tau population or you just lumped all the patients together regardless of their what their tau PET results, in both populations, it slowed the progression of disease. Again, did not stop disease progression, but slowed it down, 35% slowing by donanemab in this group at 76 weeks and 22% in the combined population. So again, what many would describe as a modest benefit in the slowing of disease progression. And just like with lecanemab, amyloid is also cleared by donanemab. You can see in the placebo arm, essentially no change in your amyloid PET scan, but significant clearance to negative or near negative levels at a median with the administration of the anti-amyloid antibody. Okay? And this is how it was done in the TRAILBLAZER trial. This was a real breakthrough. Amyloid PET scans were done to see if you could stop giving the drug because you became negative, and if an amyloid centiloid score was less than 11 on any single PET or between 11 and 25 on 2 consecutive PET scans, the drug donanemab was switched to placebo, with the logic there being that if you don't have significant amounts of amyloid left in your brain to be cleared, why are you still giving someone the drug to clear it? Okay? But we've talked about how it can slow the progression of disease. There is this significant drawback. Many of you who may be reading brain MRIs here have been asked to read ARIA, amyloid-related imaging abnormalities. Both drugs have ARIA, can cause ARIA-E, which is edema, and ARIA-H, which is hemorrhage. If you're discussing this with clinicians or patients, please note that there's actually a significant rate of ARIA-E and H with even the placebo. Okay, so you really should emphasize the difference between the two. All right, and with that, I'm going to hand this off to John. Thanks, John.
Thanks, Phil. I'm going to build on Phil's excellent presentation to talk about how we can use quantitation in amyloid PET to improve our interpretation and make treatment decisions. So what are the roles of quantitation for clinical amyloid PET interpretation? They can assist with the accuracy of visual reads, so they can make you more confident or help you with cases that are challenging. Importantly, they can estimate the severity of the amyloid burden, which can influence clinical diagnosis, because at very low levels that are abnormal, that may not explain a patient's symptoms. And then finally, in my experience, probably the most important is measuring changes in amyloid burden during or after treatment with an amyloid-targeting therapy to guide treatment decisions. And this could be as early as 6 months up to 18 months after starting the therapy. And we'll go through this in examples. And this little box below, you'll see for the approved amyloid PET tracers, this is in the prescribing information. So the FDA recognizes quantitation as part of the interpretation. The basis for how we're doing quantitation in amyloid PET is relatively straightforward. It's based on SUV ratios. So if you read oncology PET, we talk about SUV max all the time. These are SUV means in a region of interest. With amyloid, it's typically going to be cortical, divided by a reference region. And clinically, typically, the cerebellum is used as the reference region. These images I've showed you are segmentation done based on MR that could be applied to PET, but other methods may use atlases or other template-based methods. And so really, it's just a ratio. And so if the SUVR is higher, that means that you have higher levels of cortical amyloid if your region of interest is cortex. Cerebellum in clinically relevant scenarios, except in some autosomal dominant amyloid, Alzheimer's disease patients, which are rare, generally doesn't accumulate amyloid until very late in the disease. So SUVRs are great, but the challenge is they're going to depend a lot on the methodology. What PET tracer did you use? What's your pipeline? Where are your regions of interest? So Centiloids are based on SUVRs, but the idea is this will allow us to compare values across PET tracers and across methodologies. I'm not going to get into this in any detail, but it's basically a linear transformation where the Centiloid value of 0 is anchored around healthy young people who don't have amyloid in their brain, negatives, and typical patients with AD at 100 who have substantial cortical amyloid. Although, because it's a linear transformation, you can have values less than 0 or over 100. That shouldn't give you pause, as long as it fits with your visual interpretation. There are a number of recommendations. So here's a joint recommendation from AMIPAD. They propose a cutoff of 10 as negative. This window between 10 and 30, they call intermediate. You'll hear me call this borderline. And over 30, reliable detection of amyloid pathology. And this is the range where often the visual interpretation is most challenging, and we'll talk about that. Here's a similar idea showing various levels of Centiloids. Here, the magic number is 12. We'll talk about why you need to be careful about using strict cutoffs. But again, 24 to 30 is where most visual readers are going to start calling these reliably positive and agree with the quantitation. But interestingly, at these lower levels that are still abnormal, they're amyloid pathology, patients won't have tau. And so in these borderline areas, someone who has significant cognitive impairment may have multiple etiologies of that impairment. But as you get higher levels, these patients are more likely to have tau and cognitive impairment from their amyloid deposition with Alzheimer's disease. There's a lot of studies that have compared the clinical and quantitative amyloid interpretation. This is data from the IDEAS study, which was a large trial throughout the United States, in part supported by Medicare and industry. And 2 main points. You can see for negative scans and for positive scans, in general, the quantitation and the readers agree. There was a relatively small number of discordant cases. And you can also see the distribution of the Centiloids with this light blue being negative, but they're using a 24.4 cutoff, and in orange, positive. And you can see the vast majority, as with these graphs, were concordant. And not surprisingly, the discordant cases clustered around this cutoff point. So that is where it can be challenging both visually and to some degree quantitatively to assign patients as positive or negative. This is a busy slide, but I show it because it emphasizes that if you look at how PET was reconstructed, is it high resolution, lower resolution, or very low resolution? If you use different processing methods, each column is a different processing method. These lines are discordant from the reference value. So the point is, the resolution of your images, the reconstruction methods can affect the cynoloids. And you can see these are relatively large changes, 10, 20 in some cases. It's particularly pronounced as you have higher cynoloid values. So it may be less of an issue around borderline or cutoff areas, but it's important to be aware of. This is a study comparing a commercial sponsor cynoloid values with two commercially available software packages for calculating cynoloids that are FDA cleared. The main point here is that 10 to 30%, depending on which method you're comparing, had a cynoloid discrepancy greater than 10. This isn't to say cynoloids don't work or they're bad, but again, I think saying a cynoloid value of 12 is very different than a cynoloid value of 14 is kind of not understanding where the state of the technology is. So what does this mean clinically? So when I interpret these, and I recommend you do this, perform your visual read prior to quantitation, make up your mind. You may have discrepant cases, and we'll talk about how discrepancies can occur. This is especially true around the cutoff in the kind of the 10 to 30 range, but it can happen with other values as well. And so I highly recommend whatever software package you're using, have a quality control step where you look at the regions of interest, the ROIs, that are used to define the SUV ratios to calculate the cynoloid value to make sure they look reasonable, because this is a potential catchable cause of error. And sometimes you're going to have to report a discrepancy, and that's okay. When you do that, though, make sure in the report that it's clear, and make sure that you emphasize, do you think this is overall a positive case or a negative case? There may be cases where you're not confident, but I would highly recommend, whenever possible, rate a scan as positive or negative, but if there's discrepancy, if it's in this borderline or intermediate zone, point that out. Report the cynoloid value in your report, as well as if there are prior cynoloid values, include the dates, and that can be very helpful to monitor clearance. The referring clinicians, once they start, if they're using amyloid reducing therapy, they're going to want these values. And so coming back to those slides where I showed various factors that can affect cynoloids, whenever possible, if you're monitoring changes in an individual patient for amyloid clearance or changes in cynoloid values, whenever possible, use the same scanner, the same amyloid PET agent, the same reconstruction methods, and the same software. It doesn't mean you can't compare cynoloids acquired elsewhere, but there is a chance that you may have differences that are methodological rather than due to actual changes in amyloid. And finally, I think this is true throughout imaging. It's certainly true in nuclear medicine. Quantitation is very useful, but don't let it override your clinical judgment. Especially as you gain confidence with visual interpretation, you will find cases that are true positive that are negative on quantitation. Again, I'll show you some examples, but don't be afraid of that discrepancy. Look into it, try to make sure it's not a technical error, make sure that you're confident in your read, but don't be afraid to override the quantitation if you're confident in your visual read. So here's just an example of quantitation done with Beta-Peer. And so here we're going from the top of the skull to the cerebellum. These areas outlined in blue are the regions of interest that are being used to define the SUVRs, which are then being used to calculate the cynoloids. And different commercial software packages may have different methods as well as different ROIs. That doesn't mean they're wrong. That's the whole point of the cynoloid, is to make these comparable. And so kind of the bottom line is this overall global cynoloid value. In this case, it's minus 13. So I usually report these as simply less than 0. And then we have some of the regions are shown here with their SUVRs as well. And these can be helpful because, especially in cases where amyloid deposition is relatively early, it can be a little bit regional. And so by looking at the individual SUVRs, particularly in the precuneus and posterior cingulate, you may see abnormal SUVR even though the global synoloid is negative. The other point to point out is, certainly with this method, there's a large amount of cortex that is not included in these ROIs. And so that's another potential way you could have a discrepancy between your visual interpretation and the quantitation. In contrast, here's a positive case. I think we can all see it's visually positive. If we look at the gray-white differentiation in the cerebellum, as Phil was showing us, you can see it's much better than the rest of the brain. And in general, it's very hard to pick out gray-white matter tract differentiation throughout the cerebrum. So it's visually positive, and the synoloid, not surprisingly, is 125, so it's quite high. And in general, all of the SUVRs in these regions are abnormal, consistent with this kind of global pattern. Here's a more challenging case, at least in my opinion. I would call this a visually borderline case. Here we have the gray-white contrast in the cerebellum. And I would say in general, as we come up, you kind of lose some of the gray-white track in multiple cortical regions. And here it looks like the cortex may be, the activity in the cortex may be having this kissing hemisphere sign. But more frontally, it's less impressive. I like to look at the coronals. I'm showing these as splash panels so you can see all the slices. You also want to review these individually. And you also want to be looking for relatively large regions, meaning we're not trying to find small areas. We want to see slice after slice, in a brain region, they're abnormal. And I would argue here in the temporal lobe, particularly on the right, but also on the left, there's decreased gray-white contrast. And in general, if you compare to the cerebellum, it's slightly reduced. But this is a hard case. And these cases where you can still see higher activity in the white matter, and you're generally calling reduced gray-white contrast, those can be the most challenging. And they're also the most likely to be borderline in terms of synoloids. So here, this synoloid is 15. Most people would say this is abnormal amyloid pathology based on deposition based on synoloids. I would read this as visually positive, but not be very happy about it because it is a borderline case. But the synoloids here matches my visual interpretation. And a clue that might support your quantitation is precuneus is a common early site of amyloid deposition. And you can see the SUVR of the precuneus stands out. And by looking at the ROIs, these look reasonable. So I don't think it's a technical artifact. That fits with my visual interpretation where it looked like cortex was in apposition. So overall, this is reasonable. And if we want to make sure, we can look and see if they've had prior other biomarkers. And in this case, CSF was abnormal and supports that this patient has abnormal amyloid deposition. But these are the cases that are challenging. I'm going to show you a little more challenging cases than you'll probably see in most of clinical practice. Usually they're easy to classify. But depending on your patients, in 10 to 20% may fall in this more challenging range. So what to do when you have borderline amyloid cases? Well, first, look for causes, including artifacts and patient factors that may cause difficulty reading or discrepancy between your visual interpretation and quantitative results. So look for patient motion. This can cause apparent blurring of gray-white matter because boundaries because they're moving. Cortical atrophy is a common cause of difficult cases. And then make sure you look at the synoloid ROIs. Make sure they're in a reasonable location. If you think the amyloid PET is borderline, if patients have biomarkers, plasma or CSF, it's worth reviewing them. Those can have errors, so don't change your read to match the biomarker, but it can help support it. I typically don't do this in my practice, but depending on who you refers, it's not unreasonable to say if you think a case is really borderline and it's right at the edge of positive and negative, that is an option, is to do additional testing. I like to use the term borderline, but only in the context of positive or negative, meaning I don't say this is a borderline, my final report is not borderline. I assign it as positive or negative. If it's truly, truly uninterpretable, you can say that, but give a reason. That should be very rare. And I know we're busy. It can be hard to reach out to referring physicians. The one good thing is these are not emergencies, so you could potentially contact them later. You don't necessarily have to call them right when you're reading it. But I think especially if you're just getting started in your practice, it's good to communicate with the referring physicians how they want to handle this. In my experience, the clinicians, the referring neurologists appreciate it when we flag these cases because these can be also challenging to manage clinically in terms of deciding whether to start amyloid-reducing therapy. So let's look at some cases. This first case is a 68-year-old woman. She does have mild cognitive impairment, but she's still working. She's still functionally independent. She does have some cardiovascular risk factors, and her Montreal Cognitive Assessment, or MoCA, was abnormal with most prominent executive and visual spatial deficits. She had a brain MR prior to PET, and she actually had a fair amount of white matter disease as well as evidence of chronic lacunar infarcts. And she's being evaluated for Alzheimer's disease as the cause of her cognitive impairment. So here's her amyloid PET scan. So let's kind of get our gray-white contrast established in the cerebellum. And I'll ask you to look and see, we do see some white matter tracks, but I would argue that in a lot of places we have less contrast than we'd like to see. And if we look in the coronal, we can see that there are regions that look fairly normal, but we also see some areas where the gray-white contrast maybe is not as good as it should be. So here is the Centiloids for this patient. It's 23. And looking at the ROIs, I think they look reasonable. So the question for you is, how would you interpret this PET scan? Visually positive and quantitatively borderline, positive. Visually negative and quantitatively positive. Visually borderline and quantitatively borderline. Visually negative and quantitatively indeterminate, or I'm not sure. And I'm showing this because this is a tricky case. I think that's fair. I'm not sure on the pre. I guess I think I've taught you something since on the post we're better. And so I think people want to call this borderline, and I think that's correct. The way I would phrase it is visually positive and quantitatively borderline positive. And it's because visually I think we have reduced gray-white contrast. The Centiloids are well above 10 to 15, which is what people consider the threshold, so they're congruent. The reason I wouldn't call it visually borderline and quantitatively borderline, although I think that's true, is I think this is a case where we can call it positive. But I think this is not the same as a Centiloid 100 where there is no gray-white contrast. It's important in your report to call it out. I like the term borderline positive or borderline negative if it's almost positive. If your referring clinicians prefer another term, I think that's reasonable. So to summarize, this is a positive case. It's in the borderline zone, but I think it is gettable. They also had a positive plasma test of p-tau217, which supports amyloid pathology in the brain. And so one thing that just of note and why it's important to report this as borderline is, depending on the severity of their cognitive impairment, if you think about this relatively low level of amyloid, although it is still abnormal, it does raise the possibility that their vascular disease in the brain may be contributing. And so again, it depends on how severe the cognitive impairment is. This is for the clinicians to figure out. But when there's a discrepancy between low amyloid level and relatively severe impairment, that may be a clue that the patient has a co-pathology. Next case is a 76-year-old man, increasing forgetfulness. On his MoCA, he had errors in orientation and serial 7s. Brain MRI was not very revealing. So here is this patient's amyloid PET scan. I'll give you a moment to look at it. Gray-white contrast looks good in the cerebellum. And I would argue it looks pretty good, but there's some areas that look like they're maybe reduced. So again, this is a case where we might start thinking about, is this a borderline positive case? And on the right, both kind of the parietal and coming down occipital, it looks like there's really not much space between, suggesting there's cortical amyloid deposition. Coronals can be helpful, and I think to my eye, this supports the idea that there's reduced gray-white contrast. And I'm just showing some key areas where it looks like there's cortical amyloid deposition. MR can be helpful, but not required. But it can also be helpful to make sure you're not dealing with atrophy, not so much in this case. So I think this is, we have some evidence of amyloid deposition visually, but the synoloid is 3. I'd point out that the precuneus is relatively high compared to the rest of the regions of interest, and I think the regions of interest look reasonable on this map. So the question is, how would you interpret this amyloid PET scan? Visually negative and quantitatively negative? Visually positive and quantitatively negative? Visually borderline and quantitatively negative? Or visually negative and quantitatively indeterminate? Or the old standby, I'm not sure. All right. Yeah, so I think this is a scan that I would call visually, I would call this scan visually positive. I think the quantitation is negative, and the issue you have is the areas with highest deposition are not in the ROIs. And this happens particularly when you have a limited sampling of the brain. It's not that the ROIs are wrong, it's just this particular method doesn't really pick them up. And actually in the definition of most synoloid calculations, the occipital cortex is not involved, is not included, and so that's a common place where you can see amyloid deposition that doesn't count towards the synoloids. And here a clue that the quantitation is falsely negative in the sense that this person does have abnormal amyloid is the elevated precuneus level. So to summarize, it's a visually positive, quantitatively negative study. The main issues, the ROIs were not including the areas with highest amyloid. And again, precuneus is not perfect, but it's a good area to look at because it can be a clue that you're dealing with a false negative synoloid. This is important to mention in the report, and if there was a clinical concern, this is a patient you might consider doing additional biomarker testing depending on the clinical scenario. So we're going to shift gears and talk about amyloid PET for amyloid-targeting therapy or response assessment. Often amyloid PET is used to confirm plasma AD test instead of baseline prior to amyloid-targeted therapy. Currently, amyloid PET is the only biomarker shown to measure cortical amyloid clearance during or after therapy. And treatment-related amyloid clearance occurs when amyloid PET levels drop below the positive threshold after treatment. It is a bit controversial what that threshold is. It's not well defined. I'm reproducing those cutoffs using the TRAILBLAZER for donanemab, but that doesn't apply to every scenario. Initially, when we started doing this, we would often do the repeat amyloid 12 or 18 months after therapy, and that still happens. But we've seen some patients where we may do the imaging as early as 6 months to evaluate clearance. So here's a case, 67-year-old man, worsening memory over the past 3 years, can't do some basic daily tasks. His MMSE is pretty good. His brain MR does show some vascular changes, and he comes in with a positive p-tau217 plasma test. And while those are not perfect, it does suggest he has amyloid pathology. And so really, we're establishing a baseline in this patient as well as confirming amyloid pathology. So good gray-white contrast in the cerebellum. I would challenge you to find white matter, gray matter contrast in the cerebrum. And you can see this again in the coronals. He has a synoloid value of 70. And generally all levels, all regions sampled are abnormal. So here's the question to you. How would you interpret this PET scan? Visually negative and quantitatively positive, visually borderline and quantitatively positive, visually positive and quantitatively positive, visually indeterminate and quantitatively borderline, or I'm not sure. And I would note those ROIs look reasonable. Excellent. So the vast majority of folks rated this as visually and quantitatively positive. And this is not surprising based on their presentation and the positive plasma blood test. So the patient was started on donanemab, and this patient was actually imaged after 6 months of therapy. So here's the repeat PET. For the sake of time, I'll go over quickly, but hopefully you can see that there's much better gray-white differentiation. And kind of comparing a few select slices, we see much better gray-white differentiation after therapy. So now their Centiloid is less than 0. And so the question for you is, how would you interpret this amyloid PET scan, and what's the next step in a patient who's undergoing amyloid-targeted therapy? No amyloid clearance, continue therapy. Partial amyloid clearance, continue therapy. Partial amyloid clearance, sufficient to discontinue therapy. Complete amyloid clearance, sufficient to discontinue therapy, or I'm not sure. So I think this is a potentially tricky case. I think visually this is negative. I didn't give you a lot of time to look. I will say often, even though when the Centiloids are cleared, they don't look quite as clean as patients who are negative at the beginning. If you thought this was visually positive and quantitatively negative, partial amyloid clearance would be reasonable. I think here, though, we have quantitative and visual complete clearance sufficient to stop amyloid therapy. So, because they've cleared, and again, we don't know what the perfect threshold, but less than 0, as long as you believe that the Centiloids is correct, is certainly normal, so you could stop if it was appropriate for this patient. One of the challenges, we don't know how to follow these patients. Should they get repeat amyloid and start again? That's something that will evolve as more evidence becomes available. And then just finally, last case, 83-year-old man, he had an abnormal amyloid PET, has AD, is undergoing treatment with amyloid-targeted therapy. His initial Centiloids were 37. He's been doing well. We're doing repeat imaging at 12 months. So for the sake of time, I'll go quickly, but this looks pretty good. I would read this as negative. Centiloids come back at 50. Is that congruent, is the question to you. Here are the ROIs. And so here are the ROIs from the Centiloid. Is this a visually negative and quantitatively positive scan? A visually positive and quantitatively positive scan? A visually borderline and quantitatively positive scan? A visually negative and technical error in the quantification, or are you not sure? Good. The vast majority of you got this right. I would read it as negative, and even if you thought it was potentially borderline positive, clearly the quantitation is not reliable. The ROIs are not in the right place, and in fact, if you look at the brain, it's been stretched. So somehow warping to the atlas failed here. This is not the cause of all errors. There's many causes, but we have found with the particular software we use, sometimes if too much of the neck is included, we get warping errors. And so if we reprocess the exact same data, now the neck is not included in what we analyze. Now the Centiloid is 1, which is much more fitting with the patient's course as well as the visual interpretation. So to summarize, they had a visually negative PET after amyloid therapy. The initial Centiloid calculations had an artifact. In this case, reprocessing fixed the error. That won't always be true. And this patient might be able to stop therapy. So take-home messages overall, the advent of disease-modifying therapies for Alzheimer's disease is changing the landscape of neuroimaging for AD. Amyloid PET is currently the gold standard for confirming amyloid positivity and identifying patients for amyloid-targeted therapies. It's also being used in clinical practice to decide when to stop or suspend treatment. Quantitation can support visual assessment. It provides a standardized measure as well as cutoffs for therapy inclusions and discontinuation of therapy based on amyloid clearance. I recommend make up your mind visually and then note discrepancies in the report. So now we have some time for questions and answers. So I think there's some on here, and if there's any in person, feel free to come up and use a microphone and ask questions. I think there's microphones circulating.
Yeah, they'll be passing around the microphones. We have some online questions already, so I guess we'll start with the first one, if that's okay, John. Yeah, please explain how to optimize the scale when reading the scan. I'm not actually sure what scale they refer refer to, but at least visually, each one of the FDA-approved radio tracers has their own optimization of how to read the scale. For florbetaben and florbetapir, it's the cerebellum. You want that cerebellar white matter to be near the top of the intensity scale, and for flutamidamol, the one that you read in a linear color scale, you actually anchor it to the pons, close to the top of the scale. As far as if you meant scale to be centiloid, maybe you want to handle that. Yeah.
I kind of took it as visual.
Visual, okay, no, right, yeah.
And yeah, I think the key, just like Phil was saying, is whatever your reference region is, try to make it towards the top of the scale. Follow the manufacturer's instructions, but you want to use the full dynamic scale. I have seen people use their FDG quantitative scale to read amyloid PET. Usually you're going to find the SUV at the top of the intensity scale needs to be brought down. So that's an important question. It is going to vary a little bit, as Phil said, by the agent. But bottom line is use the full range of your color or grayscale.
Yes. Second question is, what type of software are people using for quantitative analysis? There's a variety, but yeah. Yeah, there's multiple approved softwares, yeah.
Exactly. Most of the major software vendors have them. Just make sure you're using an FDA-cleared software. You can, we have a different approach for our research scans than our clinical scans. I prefer an FDA-cleared because it's FDA-cleared. But there are a variety available, and there are differences, as I showed in that in one of my slides, but I think all of them work reasonably well.
Mm-hmm. The next question is, does Medicare cover amyloid PET? That's a complicated question. I'll first start by saying just because an amyloid PET is covered does not mean that you're going to get full reimbursement for the cost of the radio tracer, and it also can differ depending on what your regional CMS carrier does reimbursement. So the answer to that is not going to be simple, and you should really be careful and check. John, any?
No, I think that's right. It's a yes with an asterisk. Yeah. But I agree. You want to know locally. We are having it covered. Even if you have issues where you're not, recouping the full cost, if you're doing the treatment, people may decide, as a group that it's worth that cost if the money at least is attributed to what you do as well, to take that small loss. But in general, it is covered, but I agree, there are caveats.
We have a question from the audience, please. Thank you.
Yeah, thank you for the excellent presentation. So what is your personal experience or your feeling about all these synthetic PET, like synthetic amyloid PET, synthetic tau PET, how useful they are? Can they play a role in actual like in treatment decision, in follow-up, or categorizing different dementia types? I mean synthetic PET created by T1-based, MP-RAGE, ASL, etc., etc. AI-based.
I'm not sure. Do you want to take that, Phil? I'm not sure.
Are you talking about Centaur?
Are you talking about, could you repeat
I'm talking about when they create like amyloid PET based on MRI, or even tau PET based on MRI, different sequences using T1 MP-RAGE or ASL. So it's a kind of current trend for the last couple of years. And I saw several grants being submitted for that. So I was curious.
So I think there's a lot of interest in how you can predict amyloid and tau with other methodologies and imaging. I would say those are firmly in the research realm. And I will say I'm skeptical, but willing to change my mind when there's data. But I don't think those are anywhere close to use. But I do think there's a lot of interest in using multimodality imaging to predict biomarker status. The difference is, with PET, we're measuring it directly. I don't know if you have thoughts on that.
Yeah, and also, I think there may be two questions within that question, but, a lot of the literature on centiloids is done by really expert labs, and who are really good at this, a lot of experience, very established workflow pipelines, which include the MRI in it, which I don't think any of the commercial software can do that. And so that's, in real life, you won't quite be able to achieve the level of consistency and accuracy that you'll perhaps see in these papers, because one of the challenges with the quantification, if you do it by templates, is it doesn't take into account atrophy, which they can do if you have the MRI to line it up with. As far as the tau is very different because the progression is very different than amyloid, and a lot of systems are doing separate quantification if it's early stage tau confined to the temporal lobes versus if it's gone outside of the temporal lobes into the frontal and cortical, as you see in the revised staging system, as you start to go from B to C to D in the staging of the pathologic biomarkers. Hopefully that unraveled that question. All right, sorry about that. Yeah.
John and Phil, thank you very much for the session. It was wonderful. I sent 2 of my questions online, but I have another third one, so I'm going to just pose them to you all together. Now, first question, when do you suggest, or is there recommendation to reassess with another PET after complete clearance on ATT? Number 2 question is, in those cases with discrepant or borderline studies on amyloid PET, do you suggest FDG PET at all at any point? And number 3 question is, can amyloid PET be useful in looking at or assessing amyloid angiopathy in combination with MR perhaps, if you're not really worried about dementia per se, but the amyloid angiopathy itself? Thanks.
Maybe the last question first. Sure. As far as amyloid angiopathy, I think that's still the domain of SWI on MRI. You got to have those bleeds before I think you bring up any possibility of amyloid angiopathy. But there certainly are case reports, and it's completely believable that amyloid angiopathy does stain with our radio tracers, and it will show a positive. ARIA, amyloid-related imaging abnormalities, ARIA-H, ARIA-E, is likely, the running hypothesis is the anti-amyloid antibody targeting the vascular amyloid in the brain and causing an angiitis and inflammation. But there's no way, the way we handle that right now is excluding patients with, more than, 4 microbleeds on evidence on SW? I think it's 4. That's our way of stratifying the patients who have amyloid atrophy. We don't do anything different on the PET, amyloid PET, to try to evaluate that. John?
Yeah, in terms of your first question about, if you've stopped or suspended therapy, when to re-image, I don't think we have a clear answer to that. I think the earliest I would think is reasonable would be 12 months, but it could be longer. The accumulation, even in people who are rapidly accumulating amyloid, is, a few % per year. Now, whether that's still true after therapy, it's possible it could be faster, but I would say we don't know the answer, so I'm kind of giving an educated guess. In terms of the role of FDG in borderline cases, I typically would not do that to establish the diagnosis of Alzheimer's disease. I might do it if there was concern for a co-pathology that I think FDG might show. For example, frontotemporal dementia, or less common things like corticobasal degeneration. Usually, though, things like CBD are not going to be diagnostic mysteries. So I would mostly do that in the setting of a co-pathology. And I think we are out of time, so we're going to have to wrap up. Thanks for your attention.
Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/KNB860.